Okay, so we had a C7 spinal cord injury, and this was from Marley, Rachel, and Bethany that did this. So, some physical changes that occur with a C7 is that there is going to be some impaired sensation and motor control below the point of injury. There's also going to be some bladder and bowel dysfunction, some disrupted autonomic nervous system function. There's also going to be some spasticity and tingling and numbness below the point of injury. Um, they could also experience some referred pain in their shoulder blades, and their ability to extend shoulders, arms, and fingers could be compromised, but they might have some dexterity. And then over time, there could be some reduced bone and muscle mass. Some cognitive changes that could also be experienced, and these are going to occur secondary to the spinal cord injury itself. But there could be some decreased attention and concentration, impaired visuospatial perception, decreased ability to resolve problems, and impaired processing speed, memory, learning ability, and cognitive fatigue. Some emotional changes that are also going to be going along with the spinal cord injury is that there could be some irritability and depression experienced, anxiety, isolation, dependency, and frustration.
Okay, there's many ways that we can assess a spinal cord. First is using some formal assessments. The spinal cord independence measure is a standardized test that addresses an individual's performance in activities of daily living and mobility specific to SCI patients. So it's similar to assessments with standardized activities, and we're just assessing those directly. And then we have the ASIA scale of impairment. This assesses motor, sensory, and it involves an anorectal examination. Provides standardization just as a mode to classify the injury for consistency and communication across disciplines. It's used by doctors, it's used by therapists, it's used by nurses. And here is the ASIA scale. As you can tell, it's just kind of a checklist of what motor functions do they have, what sensory functions do they have, and then they sum it up at the end. Then for informal assessments, we've got our functional observation of a task. With C7, we would likely expect to see some, but not all of the upper extremity function to be impaired. So it's really important to learn about these barriers to function by seeing them in an authentic context. So we've got a couple of ideas for you. You can do a grooming activity, a cooking activity, dressing, or just really emphasizing things that use the upper extremity. Then we've got our sensation and active range of motion screenings. And for these, you can just do them really quick to gain some insights into what areas of the body the patient has sensation and what areas they're able to control.
And then we move into our interventions. The first one we talked about was tenodesis grasp training, which can be performed with splinting or taping of the hand or the wrist. And this allows the client to regain some function in grasp without needing the normal neuromuscular connection that's required for the contraction. The next one is functional electrical stimulation, or FES, which is artificially simulating muscle movements to complete certain functional activities. And this has the potential to improve neuromuscular connections over time if you keep them going. And then the next thing we talked about was a sort of memory game, which can improve your short and long-term memory, also your visual memory, and some motor function. And we talked about doing things like matching familiar photos or using songs that the patient would have known beforehand, or writing a story using Post-it notes or note cards with familiar memories that they may have. That is all we have for you. Here are references, and thank you for listening. How do we save? Oh, I think you just